Hey everybody, if you can hear some background sounds, sorry about that, ignore it, can't do much about it. 15% of the cardiac output will go directly to the brain due to the two internal carotid arteries on either side of the neck and the two vertebral arteries that come and join and make the circle of Willis. The normal blood flow is about 700 to 750 milliliters per minute, so quite a lot of blood. And the internal carotid goes straight through the carotid canal into the brain and into the cavernous sinus. The vertebral artery comes from the subclavian, and that goes through the C6 through C1 foramen transversum, so on the sides, and through the foramen magnum into the brain. And as you can see here, it comes from the left subclavian. The internal carotid branches will pierce the cavernous sinus and branch into the ophthalmic artery. So it goes up and here where it branches. So part of it loops backward, and it's a very short area, and that is going to be the posterior communicating artery, and that communicates with the vertebral artery. So that would be the circle of Willis right there. The anterior choroidal artery is kind of small, also kind of points backward, and that supplies the ventricles, particularly the fourth ventricle. The anterior cerebral or cerebral artery is one of the main ones, and it kind of like loops up, and then it supplies the cortex, parietal lobe, and in the middle cerebral artery is a direct continuation of the internal carotid. So it's not branched. This is like the main highway, and it's the only one that like ends. And then the ophthalmic artery is the only one that projects forward and supplies the eye. So the vertebral arteries are found in the suboccipital triangle. Review your anatomy. And once in the brain, they anastomose at the pontomedullary junction, and it branches at the pons to make the Pontine artery, and into the ear, where it will become the labyrinthine artery. And the anterior inferior cerebellar artery will supply the medulla and the anterior inferior aspect of the cerebellum. The superior cerebellar artery will supply the superior cerebellum and the pons. And the posterior cerebral artery is going to terminate and end in the occipital region of the cerebrum. So as you can see here, this would be the carotids, go up here, and then this is the circle of Willis, and these would be the vertebral arteries. So imagine this is going to be like the neck is going to be in between these large arteries, and there they join to the basilar. And then right here would be the posterior cerebral, and we're going to go through the communications later, but this is the general structure of everything. Keep this in mind. Middle cerebral is the direct communication of the internal carotid. Remember, the external carotid is going to supply the face. So internal brain, external face. Okay, so the circle of Willis, this is the basilar artery. It comes into the interpeduncular fossa, and it's going to be the main supplier of the brain. It's required to continue the blood supply and avoid blood flow. It's also known as God's gift to humanity, because this is the way the brain is able to receive so much of the cardiac output, and it's also like a built-in backup system. So if anything fails on either side, there is a lot of communication, there's a lot of anastomosis, so it can partially make up for a lack of blood flow. So any kind of like ischemia is not going to be good, but there is still like ways for the brain to receive blood, and that's due to the communicating arteries. So the anterior communicating arteries are going to be the large ones. Posterior is going to be the smaller ones, and they're going to connect the internal cerebral artery to the posterior cerebral artery. And then the optic chiasm and pituitary glands are also in this region. Kind of keep that in mind. So if there's any kind of pituitary adenoma, it might compress on one of the branches of the internal carotid. Okay, so the anterior communicating artery is the most common site of the common site of aneurysm in the circle of Willis. And any damage to that will cause damage to the lower extremity motor neurons and the sensory cortices. The communicating regions are prone to aneurysm because there is no tunica media. It's going to be thinner than the rest of the arteries. Why? Just development. The middle cerebral artery is the lateral side. It's going to supply the lateral part of the brain. And if it's damaged, the trunk, the face, the upper extremity of the motor and sensory cortices, along with Broca's and Wernicke's area, are going to be affected. So this person is going to have paralysis or weakness of the trunk, face, and arms. And they're going to have either problems understanding or speaking. The lateral striate branches of the middle cerebral artery will supply the internal capsule and the basal ganglia. And if they stroke, they're the arteries of like strokes or common for hemorrhage. And damage to this is going to affect the sense of balance and coordination. The posterior cerebral artery will supply the occipital lobe, and they usually go hand in hand with cranial nerve 3 palsy, so there's going to be problems with vision, particularly accommodation. The meningeal artery, remember this from anatomy, it will supply the intracranial Dura Mater. It rises from the external carotid and the internal carotid. And the anterior meningeal artery will arise from the ophthalmic, and the anterior posterior ethmoidal artery will supply the anterior Dura Mater. A lot of words, I know. The middle meningeal artery will form the external artery, and it goes through the foramen spinosum, which lies right between the skull and the Dura Mater. And it's going to divide into the frontal and parietal branches at the telion. And this is the one that supplies most of the Dura Mater. Any trauma to the side of the head is going to cause an epidural hematoma, or hemorrhage, also known as hematoma actually. And that's just because it lies so close to the surface of the skin, like right between the skull and the Dura Mater. And the posterior meningeal artery is a branch of the ascending pharyngeal and occipital artery, also known as the carotid artery, and that will supply the posterior cranial fossa. So this kind of like supplies the entire like back end of the brain. The vertebral arteries will come from the subclavian, and once again make the basilar artery. And the main branches is going to be the anterior spinal artery, and that it innervates the majority of the spinal cord. And then the other branch would be the posterior inferior cerebellar artery. Some ascending or additional branches would be the ascending cervical branch and the intercostal branches, and those are joined by segmental arteries just to kind of like form a plexus. Pica is going to be the posterior inferior cervical artery, and the posterior spinal arteries, for the most case, it will arise from the pica, and a large minority will come directly from the first part of the cervical vertebral artery. This is just kind of a anatomic note you have to keep in mind, especially if you are going to be operating on the neck region involving any kind of like spinal cord. So everything eventually just drains into the dural venous sinus, and that all drains into the internal jugular vein, which eventually goes into the superior vena cava. So the problem with any kind of infection involving, like meningitis and whatnot, is because there are no valves in the veins of the brain. So bacteria can kind of go everywhere. That's why it's so concerning if something can pass through the blood-brain barrier. Another important thing to note is that the superficial middle cerebral vein will empty into the cavernous sinus, and any kind of infection in the cavernous sinus can just like go from the cavernous sinus straight into the middle cerebral vein, and then from there like straight sinus, and then IVJ. So more connections. The deep middle cerebral vein will be joined by the anterior cerebral and the striate veins, and that makes the basal veins, and that makes the great cerebral vein, and all of that drains into the straight sinus. The same kind of goes with the internal cerebral vein. It will be joined by a bunch of other veins, and along with the great cerebral vein. So the deep middle cerebral veins joins a bunch, makes the great cerebral vein, and then the great cerebral vein will join the internal cerebral vein, and then all of that empties into the straight sinus. I wonder how many times I said cerebral and said it wrong. Sorry. Okay, so the veins of the spinal cord are, we're just not going to name them. There's just 6 very windy and loopy, that's what tortuous means, longitudinal plexuses, so it goes up and down. And those communicate superior in the skull with the veins of the brain and the venous sinuses, and they will all join into the internal vertebral venous plexus, and then from there into the vena cava. So there are the 3 meninges. The Dura Mater comes from the mesoderm, while the arachnoid and the pia are ectodermal. And what's important to know is the arachnoid meninges will have trabecula. Dura Mater is going to be the outer endosteal layer, and then there's going to be an inner meningeal layer. And all of them are like, they're very firmly attached to each other, except for where they split to enclose the venous sinuses, and then the inner layer is folded to form like a septa. So if an epidural hematoma occurs, like when you damage the middle meningeal artery, it's going to be very problematic because it compresses the brain. Why? Because it's the skull is going to hold all of the blood in, right? So it can't swell outwards, it has to swell inwards. And the dura will have these septa, and it doesn't allow like the blood to spread either, because it's so firmly adherent to like the cranium. So in this person's hematoma, it can only spread up to there, and that's it. The only other place to spread is inwards. So epidural hematomas are pretty bad. Same goes with the subdural hematoma. It's going to be just somewhere else, right? So the epidural is going to be like trauma, torn meningeal artery. Subdural is going to be right below the dura, and that's also problematic because, like I said, the adherence is not going to allow the expansion for the swelling. Okay, so the arachnoid matter is vascular, and it has a bunch of processes or villi, particularly around the sagittal sinus, and those are going to be made out of specialized mesothelial cells, and those will absorb the CSF because the space contains CSF. As you get older, the villi get large, and they make these pedunculated tufts, also known as arachnoid granulations or Paconian bodies, and those will interfere with the cell's ability to absorb the CSF. And eventually, or in some cases, it can lead to like swelling, and this will push the brain into the cranial vault, making these like depressions. And there is some correlation with these Paconian bodies and dementia. Pia mater was going to be held very tightly to the brain. It follows the surface irregularities. Cisterns are going to be large pools of CSF, and all of that is basically used to cushion the brain. The cerebellomedullary cistern is going to be the largest one. So you can hear, here it is, and it's near the fourth ventricle, and it's the cisterna magna is going to be used for a cisternal puncture if a lumbar puncture isn't possible. This is usually very, very rare because it's kind of risky. It's the only system that directly communicates with the ventricular system of the brain, and any kind of introduction of foreign material and pathogens can cause like truly horrendous meningitis or infection, and it's just going to go rampant through the brain because, once again, there are no veins of the brain, or there's no valves in the veins of the brain. Sorry. Pontine system, a cistern is going to be, well, here's the pre-Pontine system, pons right here. It's going to be on the ventral surface of the pons, and it contains the basilar artery. And the interpeduncle system is going to be at the base of the brain and between the temporal lobes, and it contains the circle of Willis. The lateral sulcus, or the Sylvian cistern, is going to be in the stem of the lateral sulcus in front of the temporal pole, and that contains the middle cerebral artery. The cisterns of the great cerebral artery of Galen, named after the Roman physician, also known as the father of medicine, that Galen, or Galen. It's also known as the cister ambiens, and that's located between the splenium of the cerebral cortex and the superior surface of the cerebellum, and that contains the great cerebral vein of Galen. Okay, meningitis. So it's going to be headaches, altered mental status, high fever, seizures, and stiff neck. That's going to be the most important one. And photophobia. So headaches, mental altered status, photophobia, stiff neck. It's classic signs of meningitis. You do a CSF analysis and read the white blood cell count. And meningitis usually affects the dura, but it's mostly limited to just the arachnoid and the pia. Why? Because the arachnoid is vasculated, remember, and the pia is just very close. Complications, I mean, these are the complications, but the most complicated complication is just death, straight up death. Somebody can die quite quickly from meningitis. In bacterial meningitis, there's going to be elevated white blood cell counts in the CSF, along with decreased glucose. And in viral meningitis, there's actually going to be decreased amount of white blood cells. Okay, so here we go. In acute purulent meningitis, it's caused by bacteria. It is going to lead to hydrocephalus if it's not treated fast enough, and the CSF culture is going to be positive. Acute septic meningitis is viral, so the motility is slower, culture is going to be negative, caused by these things. Glucose in the viral is going to be high in comparison to the low amounts in bacterial meningitis. Fungal is also going to be low. So the most dangerous ones you got to be worried about are the bacterial and the fungal meningitis. Okay, so CSF, predominantly made out of the carbonic anhydrase. It has some role of filtrating blood, but the main role is to cushion the brain. Alright, so here's the circulation. Spinal cord goes up, it kind of goes around, like front and back, goes up, gets absorbed into the fourth ventricle, goes through the aqueduct of Sylvius, and then kind of like goes again and again. Here's the foramen of Monroe, aqueduct of Sylvius, there you go. So everything kind of comes back into here and then leaves and goes around. Spinal taps. Why do we use it? Infections, oncology, all of that good stuff. Um, you use it sometimes to introduce antibiotics. That's kind of rare. Anesthesia, caudo anesthesia is what it's for. If we want to scan for cancer, it's xanthochromia is when there's a change of color in the CSF. Usually there's like red if there's like blood, but you got to be really careful because the red blood cells in the CSF could be just due to a bad spinal tap. That could be because you have accidentally went through a vessel. So it's really important if you see, you know, red blood cells in the spinal tap to kind of like read the numbers, make sure it's, you know, not just like a couple red blood cells. You have to make sure it's like quite a bit, or you'd have to repeat the spinal tap. So that's kind of important to keep in mind. Like, not every spinal tap is going to be perfectly full of just CSF. Like, sometimes there is red blood cells. So you want to be worried about the amount of white blood cells, gamma globulins, proteins in it, and the pressure. Hydrocephalus, just increasing the volume of cerebrospinal fluid in the brain, could be caused by excessive production or an obstruction or abnormal absorption. And an internal hydrocephalus is non-communicating. It's only going to accumulate in the ventricular system. There is going to be a blockage that caused it. External hydrocephalus, it's going to communicate with the spinal cord. So the hydrocephalus is going to be a problem kind of like everywhere. So it could be caused by glioblastoma multiforme, and that's it's going to be cancer of the glial cells. Glial cells will make too much it's going to make too much CSF. Meningioma, cancer of the meninges. It's also going to form too much CSF fluid. Schwannoma, ependymoma, and medulloblastoma are much more rare, but kind of same deal. They just produce too much cerebrospinal fluid. So that's it for now. Thank you for your attention, and good luck studying.